Good evening, everybody. On behalf of MCure Pharmaceuticals, we welcome you to this webinar. It's been a tradition by the HIV division of MCure to host a webinar after the AIDS conference every year, and we continue in this tradition. And happy to bring to you the highlights of the AIDS conference that was held recently in Munich. To introduce the speaker, we have Dr. Ketan Kulkarni from our medical division of MCure Pharmaceuticals. And Dr. Ketan, after his introduction, will hand over the floor to Dr. Sanjay Pujari. Participants can post their questions in the chat box so that at the end of the session, we can still bring up these questions for the opinion of Dr. Sanjay Pujari. Over to Dr. Ketan.
Thank you, Mr. Balaji. I welcome all the doctors for this updates on the AIDS Conference 2024, which was held in Munich. And I wish you all of you a good evening. So it gives me a great pleasure to welcome for this esteemed webinar, Dr. Sanjay Pujari, sir, who is joining us from Pune. So, sir is a MD in internal medicine, and also he is a fellow infectious Diseases Society of America. He is the director and chief consultant, Institute of Infectious Diseases in Pune. He is a consultant in HIV medicine and infectious diseases at the prestigious Pune Hospital and Research Center in Pune, which is in Maharashtra, India. Sir has been the principal investigator for the Treat Asia, that is a therapeutic research education in AIDS treatment at Pune site, and also for the START study, which is a strategic timing of antiretroviral treatment in Pune site. Dr. Pujari sir has presented and published numerous papers nationally as well as internationally, around 100 PubMed indexed citations. Sir has been the faculty at numerous symposiums, including the European AIDS Clinical Society Advanced course from 2014. And I welcome sir for this webinar. And I invite Dr. Sanjay Pujari sir to take the session forward and share his valuable insights and updates. Thank you very much, sir.
Okay, thank you. Let me share my presentation. Okay, good evening, everybody. At the outset, let me thank MCure for inviting me to this tradition of theirs to summarize AIDS-related updates from the AIDS conferences held every year. So this year it was held in Munich, and predominantly the clinical science was based on the emergence of injectable antiretrovirals, both in treatment and prevention. However, I would like to focus on some of the clinical issues that are relevant to low and middle income countries. With that in mind, this is the outline of my presentation. I'll briefly discuss some studies on antiretroviral therapy. We'll focus on a few studies on comorbidities and adverse events. Also, some very interesting studies on prevention, both for HIV as well as STIs. And finally, one of the newsmakers of the conference, and that is the 7th cure that we had, which was reported at the conference. So the first study I thought was interesting is to look at the role of the dual drug DTG3TC in individuals infected with HIV with occult co-HBV infection. Now, we all know that we need to rule out active HBV infection prior to initiating DTG3TC, either in naive individuals or in the switch situation. So what this study looked was a retrospective analysis of 4 phase 2-3B studies of DTG-3TC versus comparator regimens, and included individuals with occult HBV infection, which is defined as antibody positive to the core hepatitis B antigen, and a non-reactive HBV DNA. And they looked at virologic HIV-related outcomes and also HBV rates of reactivation, as well as abnormality in liver chemistry after switching or initiating DTG-3TC. So in naive individuals, data from the Gemini 1 and 2 studies, as well as the STAT study, was analyzed using the occult HBV population. And as you can see here, whether it is including TDF or not as comparator regimen with DTG-3TC, you see over 144 weeks, no difference in the rates of virologic suppression between these two regimens, as well as no increased risk of HIV RNA being more than 50 copies. And further looking at more detailed analysis of target not detected, and you can see hardly any difference between the two regimens. And the same was true with the DTG-3TC in the STAT study. Of course, the numbers were very small in this study, and that's why you see the percentages being big in terms of virologic non-suppression. In the experienced individuals, we had the Tango and the SALSA studies, where individuals were switched to DTG-3TC, and amongst those who were occult HBV positive, at various week endpoints, you can see here right up to week 144, there was no difference actually in the HIV suppression rates between DTG-3TC and the comparator 3-drug antiretroviral regimen. And that was also true for higher number of suppression when it was defined as less than 40 or target not detected. The Tango also had an open label extension, and there was a late switch to DTG-3TC among individuals who finished the primary Tango trial. And even in this extension, which is up to 196 weeks, you can see here, there is not much difference between the two arms. So in terms of implications for practice, of course, we need to rule out HBV infection screening with HBsAg prior to initiating or switching to DTG-3TC. But this analysis really demonstrates that perhaps it may not be necessary to rule out occult HBV infection when we want to switch individuals to a 2-drug regimen of DTG-3TC, because it doesn't affect HIV-related virologic outcomes. And in the same study, they didn't see any HBV reactivation happening. Neither did they see increased liver enzymes, except in one patient who concomitantly got HEV infection, and mostly was related to that situation. And also it was reasonably safe, similarly safe when you compare both the regimens together. The second study again focuses on the 2-drug DTG-3TC, and this is the PASO doubles trial, which was carried out in 39 sites as a phase 4 study in Spain. It was a non-inferiority studies in which individuals were virologically suppressed but were taking different regimens, which usually had more than one pill once a day, so more for simplification. And of course, key exclusion criteria included no exposure to prior dolutegravir or bictegravir, and no evidence of prior virologic failure. So those individuals were randomized to a 2-drug regimen of dolutegravir 3TC and compared with TAF FTC bictegravir. Prior to this, we should remember that Tango and the SALSA trial actually looked at DTG based either TLD or TAF FTC DTG, but this was one of the first studies looking at the comparison of dolutegravir 3TC with the 3-drug bictegravir based regimen, and the current analysis focused at 48-week results. And using the FDA snapshot virologic outcomes at week 48, you see no difference in virologic suppression rates defined as HIV RNA less than 50 copies between switching to a dolutegravir lamivudine versus switching to a TAF FTC bictegravir based regimen. What was interesting was the weight gain changes, and here is one of the analysis looking at the proportion of individuals who had a weight gain of more than 5% post switching across the two arms, which is also stratified according to what they were taking prior to switching in terms of the NRTI backbone. So if they were taking TAF and then they switched to either DTG3TC or TAF FTC bictegravir, you see a little less weight gain with the DTG3TC while continuing to gain weight with the TAF. The same is true with abacavir. But what is interesting is TDF. We all understand now that TDF has weight suppressing effect. So when you switch away from TDF, there is a suppression of the suppressive effect leading to weight gain, which happens in both the arms. But subsequently, there is also a TAF, which is associated with the more weight gain, perhaps, as has been demonstrated in this. Almost 40% of individuals had a more than 5% weight gain. Another study, again, looking at the two drug combination called the DIET study, which basically looked at switching from bictegravir based regimen amongst virologically suppressed individual in a phase 4 open label non-inferiority single center study. And of course, the key inclusion-exclusion criteria were concomitant active HPV infection or prior virologic failure or prior INSTI resistance. Now, this is a study with large numbers in the sense that it has not been studied very well. In the previous Tango and Salsa studies, switching away from a bictegravir-based regimen to a two-drug dolutegravir-based regimen. And as you see here, individuals were randomized to a two-drug DTG3TC or were allowed to continue with the TAF FTC bictegravir, and the current analysis reporting 48-week results. And again, here using the FDA snapshot virologic outcomes at week 48, you see no difference in the rates of virologic suppression between switching to DTG3TC versus continuing TAF FTC bictegravir. What was interesting is safety in terms of renal safety, creatinine, and eGFR. There was a slight statistically significant decline in eGFR, which happened in the DTG3TC arm as compared to the TAF FTC bictegravir arm, which can't be explained really. But mostly the differences as far as creatinine was concerned was statistically non-significant, as well as there was not much difference statistically in terms of weight, as has been shown here, changes in weight or changes in BMI, and also lipid parameters, changes in total cholesterol and changes in LDL cholesterol across these two arms. Any difference of these were not statistically significant. So what do we learn from these two DR DTG3TC based studies is switching to DTG3TC is an excellent option, particularly when we are talking about simplification with pill burden, where for people who are taking more than one pill a day. But for those individuals taking one pill once a day, which usually includes TDF or TAF, and if there is associated toxicities associated with that, or proactive switching to prevent development of those toxicity, this is an excellent option. There may be a signal towards renal weight and metabolic advantage over switching to TAF-based regimen when paired with bictegravir or DTG. But of course, TAF has its own issues in terms of weight gain and dyslipidemia. But in this study, as I've shown you in the DIET study, there was not much difference, at least at week 48. We need long-term data to confirm that. The other interesting long-term data which was presented for week 144 was the SOLAR 3D. This is one of the trials which basically looked at individuals who had a historic failure to lamivudine, either determined by historic presence of resistance report showing a 184VI or assumed to be clinically resistant in terms of 3TC. So to summarize the design, these are treatment experienced patients who are on a stable 3 or 4 drug ART and have been suppressed on that 3 or 4 drug ART for more than 6 months and had a prior historic 184VI mutation and also had prior virologic failures. And this is not a randomized trial, but they compared individuals' outcomes in terms of HIV viral suppression between those who had 184VI versus those without 184VI at week 144. Normally, you would expect that we normally say that if there is 3TC resistance, you should not basically switch individuals to two-drug DTG-3TC. But what you see here was at week 144, there was really no difference in virologic suppression rates between individuals having a 184V versus not having a 184V. Incidentally, in this study, there was almost, I think, 30-40% individuals who had archived resistance documented for 3TC when they switched. But this was not really present because these individuals were virologically suppressed. So that archived resistance was documented from DNA PB in the PBMCs. And even in that situation, they saw a suppression of HIV by switching to by having on DTG-3TC as compared to somebody who was not having the 184V mutation. Of course, the numbers of this are very small. I think it's not more than 50 patients in each arm. What is interesting is something which may have some implications for practice. So it can be considered perhaps even when we have a historic evidence for 3TC resistance, but that has to be extremely individualized. So where I would see the role is where you have an individual who's suppressed on a 3 or a 4 drug regimen for a prolonged period of time, preferably more than 6 months, more than a year. And these individuals have, for some reasons, contraindication for TAF, TDF, abacavir, and darunavir, ritonavir PI-based regimen is unaffordable. So in that situation, perhaps you can switch these individuals to a two-drug DTG-3TC, but with the caveat that you need to closely follow up with virological monitoring for identifying the failure earlier, preferably initially every 3 months viral load monitoring. Let's switch gears to sequencing of antiretroviral therapy with first-line NNRTI failure. And there were 2-3 studies which were presented looking at this hypothesis, this question. And one of the studies is the D2EFT study, where it's a phase 4 study across multicentric countries in the world, where individuals failing an NRTI with 2 NRTIs and with no prior PI or INSTI-based exposure were randomized to a standard of care, which is 2 NRTIs with darunavir, and 2 new classes of drugs like darunavir with dolutegravir. Subsequently, they also added the TDF-XTC DTG arm after the results of the Downing and the Nadia study were presented. What this data looks at is 96 weeks final data for virologic outcomes and safety. And as you can see here, the standard of care with 2 NRTIs and darunavir, and the 2 NRTIs here were determined either by resistance testing or sequencing. If somebody was on TDF, they switched to AZT, etc. But in these individuals, there was a virologic suppression rate of around 73%, and you had no difference really between these 2 arms of dolutegravir with darunavir and dolutegravir with TDF-XTC, in spite of individuals using TDF or having TDF resistance by resistance testing. The TLD regimen worked fine in terms of sequencing. In terms of weight changes, there was, of course, no statistically significant difference, but mostly the 2 NRTIs with darunavir, ritonavir had lower weight gain as compared to the maximum weight gain that was seen was with DTG darunavir combination. And then you had TDF-XTC with DTG being in the intermediate zone. The other trial looking at the same question, basically coming from Africa in Zambia, where patients switched to DTG and compared it with boosted PI, either with lopinavir, ritonavir, or atazanavir, ritonavir, and changing the nucleosides if they are failing a TDF-based regimen, an NRTI-based regimen, TLE regimen. So as you see here, they had two arms here. One was less than 1,000 copies at failure, and other was more than 1,000 copies. And this analysis at 144 weeks looked at more than 1,000 copies. And you can see at the forearm that individuals failing were randomized to either TLD or TAF-FTC-DTG, and then zidovudine 3TC either paired with lopinavir or atazanavir. Now, what you see here is that the lowest virologic suppression rates in individuals were switched to a PI with sequencing from tenofovir to zidovudine, again replicating the results from the previous trial, like the Nadia trial. And the TDF arms, in spite of significant TDF resistance when paired with dolutegravir, was actually superior in terms of switching to a boosted PI based regimen. And those who failed, there were virologic failures in all the arms, but amongst those who failed, the emergent resistance either to NRTI or an integrase inhibitor was not present in any of the integrase arms. But in the PI ritonavir arm, you had emergence of zidovudine resistance, NRTI resistance, as well as some PI mutations happening. So both in terms of virologic efficacy as well as emerging resistance in the context of virologic failure, the TLD or the TAF-FTC-DTG arm performed better as compared to switching to a 2-NRTI boosted protease inhibitor. So what are the implications for practice? In that sense, switching to an INSTI-based regimen after an NRTI failure is effective, even if you recycle the same backbone nucleosides. Now, there is strong evidence from multiple trials, including long-term data from the Vicent trial for 144 weeks. And what is important, of course, is some signal from the Nadia trial, which demonstrated that those who had virologic failure on DTG-based regimen, some of them had integrase resistance, but in those individuals, it was usually the backbone that was used was the ZT3TC. But what is interesting is once you switch these individuals, and if you're worried about virologic failure, you need to identify that early by close virologic monitoring when you want to continue tenofovir from first to second line. There's another interesting context which we talk about. Many of our patients on a second line boosted PI regimen with backbone nucleosides, they're doing fine, they're virologically suppressed either on atazanavir or darunavir, for instance. But in this study, it was atazanavir and lopinavir patients where individuals were suppressed, and then they were randomized to switch to bictegravir based regimen or continue the backbone PI. Remember, we had the 2 SD studies published in New England Journal last year, which demonstrated that in this context, when you switch to a dolutegravir-based regimen, it works fine. So this study tried to look at whether when you switch to bictegravir-based regimen, it should work as well as DTG. So as you see here, there is no difference in the rates of virologic suppression when you switch a suppressed PI-based regimen to either continuing the PI or switching to a bictegravir. So it looks like for most people who are on a boosted protease inhibitor, whether it is second line, third line, who are virologically suppressed, you can safely switch them to an INSTI-based regimen. The most important aspect is, of course, they should be virologically suppressed when you switch them in this context. Let's switch to some comorbidities and adverse events. We have the first study coming from Africa again. This is the Acacia trial, which basically also got published in the Clinical Infectious Disease around the same time. So as you see here, we all know that you screen individuals with low CD4 count with a CRAG, a serum cryptococcal antigen, and those who are positive, you basically do a lumbar puncture and rule out cryptococcal meningitis. If there is no meningitis, then you give them a fluconazole treatment over a period of 24 weeks in these doses here. What the investigators did in this trial was stratified individuals as low cryptococcal antigen titer and high cryptococcal antigen titer, defined as 1:80 and more than 1:160. And amongst those with low titers, they gave an additional dose of liposomal amphotericin B, 10 milligram per kilogram, as a single dose. Remember, this is a dose which is used in the Ambition CM trial for managing cryptococcal meningitis along with fluconazole and flucytosine. So essentially what they did was they gave the liposomal amphotericin B as if the patient had meningitis. And then they looked at 24-week meningitis-free survival in this group of patients. And as you can see here, there was hardly any benefit of adding a liposomal amphotericin B 10 milligram per kilogram over fluconazole as standard of care for a period of 24 weeks when you consider a meningitis-free outcome. So what is the implications for practice? I think this field is very interesting in the sense that we may be seeing in future routine monitoring of quantitative crack titers, and there are lateral flow assays which are currently available but not yet approved by the FDA in the US. But that will help us to determine whether you want to do a lumbar puncture, particularly if the titers are very low, as defined as 1:80. And then if the titers are low, whether we really need to give fluconazole preemptive therapy for 24 weeks, or we can get away by giving preemptive treatment for 10 weeks or 14 weeks. So that is something which is quite interesting. The other issue is always about DTG and birth defects, and there was some data presented from antiviral pregnancy registry, where prospectively reported pregnancies with history of ARV exposure and the trimester of exposure data was available. And this was compared with population level birth abnormalities in terms of live births as well as birth of babies with defects in the general population. And as you can see here, in terms of live births, whether it is any of the integrase-based regimen that is DTG-based, when it is paired even with abacavir 3TC or one of the tenofovirs, the proportion of live births is quite similar. And the rates of stillbirth, spontaneous abortion, and induced abortions, etc., are similar to the general population. So that essentially means that we don't need to be worried about DTG's effect on pregnancy, periconception, or in pregnancy. The other interesting study I found was looking at individuals with sleep abnormalities on DTG based, who are virologically suppressed on DTG based ART. In these individuals who had a insomnia index of more than 8, they were randomized to continue DTG ART for another 120 days or switch to bictegravir based ART for 120 days. The numbers are really small, as you can see here. And what they actually measured were patient reported outcomes. There are a host of questionnaires, and as well as they did functional MRI of the brain to see whether the functional connectivity networks improve and also impact on soluble inflammatory markers. Well, they did not see much improvement in soluble inflammatory markers. They definitely saw an improvement in patient-reported outcomes, both in the insomnia index as well as the SPF 36. You can see here, on switching to bictegravir, sleep abnormalities were reported to be lower when you switch from DTG to bictegravir. And they had MRI pictures, and as you can see, these are the yellow areas here, which basically indicate that these are enhanced connectivity at 120 days compared to baseline, and this is supposed to be better in terms of resolving sleep problems in individuals switching away from DTG. The other interesting aspect with DTG as it is being scaled up is the impact on diabetes, is the impact on weight gain, impact on incident hypertension, and impact on CVD. All of this has been analyzed as DTG is being scaled up in Africa as well. So this is a 4-country trial, 4-country report prospective cohort from Africa, where individuals living with HIV and though were compared with those without HIV. And then they were initiated on ART, the HIV positive individuals, and over 5.4 years, hypertension assessment was done, and the incident rates were calculated. And this is a complicated slide, but if you see here, with various ARTs that are being initiated, whether when you compare it with DTG versus efavirenz or DTG versus nevirapine, DTG versus boosted PI, or DTG versus people without HIV, you actually see no difference in the incidence of hypertension in unadjusted and two adjusted models. There was only a signal for DTG being associated with hypertension when you compare it with nevirapine across all these three analyses. But overall, it looks like DTG may not be associated with incident hypertension in this large cohort study from Africa. So to summarize this aspect of comorbidities, it's very with integrase inhibitors. I think DTG is now considered very safe peri-conception and pregnancy, and is recommended for women of reproductive age group, regardless of conception plans or pregnancy. Sequencing from DTG to bictegravir may help in the small proportion of individuals who may have complaining of sleep disturbances. We don't have data for the reverse problem. And finally, hypertension association with integrase inhibitors needs further study. But at this point of time in our clinics, we have been monitoring blood pressure at every follow-up visit of patients and be proactive for managing hypertension in these individuals. We all know about the REPRIVE study, which demonstrated 36% reduction in MACE when individuals between 40 to 75 years with low to moderate atherosclerotic cardiovascular disease risk, as measured by the pooled cohort equation, were randomized to pitavastatin and placebo, and guidelines have changed in the developed world in terms of recommending for most individuals who with HIV infection between this age group to be put on a pitavastatin or a moderate intensity statin like atorvastatin 20 milligram. Now, within this REPRIVE study, the investigators looked at whether abacavir exposure has a higher risk of MACE. And as you can see here, they selected a population who were exposed to abacavir. Almost 22% of their trial participants were exposed to abacavir. 9% were former, 13% were currently using abacavir. And what you see here is abacavir being associated with a higher incidence of MACE events versus some participants who never were exposed to abacavir. So what does it really tell us is in terms of, and of course, in this study, they also looked at PI exposure and TDF exposure, and there was no difference in terms of incident MACE in this population. So it really tells us that there may be some issue with abacavir and cardiovascular disease risk. And abacavir 3TC DTG is something which is used often for renal individuals, patients with renal problems. But I think we have some alternatives available now, particularly with two-drug DTG 3TC. So effective alternative regimens switches need to be explored in this population. Let's switch to prevention. One of the important aspects is oral PrEP with TDF-XTC or TAF-FTC. And this is one of the largest studies reported until now from the US, which looks at the renal safety of oral PrEP. And this, we are talking about 12,183 people initiating PrEP either with TDF-FTC or TAF-FTC. And they had an eGFR measurement 1 year pre or post PrEP initiation. And then they modeled this and also compared individuals, the odds ratio between these two in terms of attaining an eGFR of less than 60 ml per minute. And as you can see here, renal safety, as far as the eGFR change is concerned, it is less with TAF-FTC as compared to TDF-FTC based regimen, suggesting that TAF-FTC may be safer as far as renal safety is concerned as compared to TDF-FTC. And this was the odds ratios looking at the development of an eGFR less than 60 ml per minute. And across all of the risk, adjusting even for all of these risk factors, including hypertension, a baseline eGFR, gender, and age, there was association of it being not great with TDF-FTC as compared to TAF-FTC. So, of course, in our practice and in people who work in STI clinics, it's very important to offer oral PrEP and monitor renal safety. Perhaps there is a signal to consider that it may be better with TAF as compared to TDF. But the problem with TAF-FTC is it is something which cannot be recommended for vaginal sex. You need to individualize it. In context of vaginal sex, TDF-FTC is still recommended as PrEP. Let us switch gears for looking at STIs, not necessarily HIV, because we all know about the French study which looked at doxy-PEP, which demonstrated a significant decline in STIs. So this pilot trial in the US looked at whether you can use doxycycline PrEP in individual in MSMs with previous syphilis. It's a small study. You can see the numbers here. Randomized to doxycycline or placebo, doxycycline being taken daily for a period of 6 months, 100 milligrams daily, and then quarterly follow-up with STI screens and assessments. And what they demonstrated was an 80% reduction in sexually transmitted infections, 68% reduction in gonorrhea, 92% reduction in chlamydia, and 79% reduction in syphilis. So this is something which is interesting, and they are going to study it in a phase 3 study using larger individuals. From Tokyo, there was a study looking at doxy PrEP amongst female sex workers, where in a private clinic, PrEP was initiated with doxy amongst these women. They, of course, did a retrospective analysis, and they targeted chlamydia, gonorrhea, and syphilis. And they compared the rates, incidence rates before and after introducing doxy PrEP in this population. And as you can see here across all the STIs, you see a dramatic decline in the incidence rates. And in fact, with syphilis, post-doxy PrEP, there was no incidence of syphilis, no cases of syphilis seen. So overall, this looks a promising strategy, but this is something which is both, of course, has a role in PEP and pre-PrEP, but the antimicrobial resistance is, of course, a main concern. If you start using doxycycline, not only will you expect some resistance which can happen amongst the organisms which cause the sexually transmitted infection, but also organisms like Staph aureus, for example, which are normally colonized in the nasal cavity. Though there are some early data to suggest that in this PEP context, there was no increase in resistance in the staph from the nasal swabs. Finally, the newsmaker of this conference, we can say, was what was the Purpose 1 study, which was carried out in South Africa and Uganda amongst young adolescent and adult girls with between 16 to 25 years, a large trial, which randomized them in 2:2:1 with lenacapavir 6 months subcutaneous injection with placebo TDF-FTC, or 6 months lenacapavir is a capsid inhibitor which can be given subcutaneously every 6 months, and a placebo of TAF-FTC, or a placebo of injection and oral tablets. Now, they were going to study the incidence of HIV infection in these 3 arms, but unfortunately, we can't have the placebo arm. So they did with recency, using recency HIV diagnosis assay, estimated the background HIV incidence and compared it with these 3 arms. And what you can see here is when the background incidence is around 2.41 per 100 person years. In the daily oral TAF-FTC, it was 2, and it was 1.69 with the TDF-FTC. And what you see with lenacapavir was 0 infections. So this trial was stopped in the interim analysis because there was 100% efficacy associated with the use of lenacapavir for prevention when given as twice yearly injection. So this is obviously a very rare result which you see across all disciplines of medicines, that a trial has 100% efficacy in terms of the important aspect of this is this looks like something which is like a vaccine, for example, which people take annually to prevent infections. This is something which can give twice yearly to prevent getting infected with HIV. Finally, let me end by cure. We know that there have been 6 cases of cure. 5 of them have been with the bone marrow transplant with the delta 32 homozygous CCR5 delta mutation. And last year in Geneva, we had last year in the IS conference in Melbourne, we had the Geneva patient who had a wild type CCR5. What is was reported in this conference is now called as the next Berlin patient, who basically had an AML and received an HSCT with wild type CCR5. So with a heterozygous CCR5. So one of the genes had delta 32 and the other didn't have. And after the transplantation, the patient was off ART for almost 5 years. He was transplanted and he was on ART for 4 years and then off ART for 5 years. And you can see here there was a absolute chimerism. There's good improvement in CD4 count. And there was detection of HIV-1 DNA initially prior to transplantation. And then subsequently, there was no HIV DNA detected in this individual. So this is an ART-free remission, which is there, which has been reported. So this is, of course, not scalable because we don't really can perform bone marrow transplants. But what it also gives us idea that you don't really need to have a delta 32 homozygous situation, and you can look at gene therapy, etc., in future of trying to help in terms of curing people living with HIV. So let me summarize by saying that though we didn't discuss much about injectable ARTs, there was a great amount of data presented at the conference looking at the potential of injectable ARVs in the current scenario, as well as for treatment of multi-drug resistant HIV. Unfortunately, the access of this is limited in lower and middle income countries, and there needs to be improvement in access and availability of these medications for people living with HIV in these settings. Of course, INSTIs continue to be the core ARV drug, whether used as a 3-drug regimen or a 2-drug regimen across treatment lines, whether it's first, second, or third line. There is a potential for using doxy either as PP or PrEP for STI prevention. Of course, AMR is a concern, and that needs further studies. And finally, we can't really treat us out of HIV by using only TASP to end the HIV epidemic, but we need PrEP. And with the results of the Purpose 1 study, it looks exceedingly potential advance in terms of trying to integrating both of this and help us ending AIDS by 2030. So these are some of the sites which helped me to prepare the presentations, and I am happy to take questions. Thank you.
Thank you very much, Dr. Pujari, sir, for bringing out the insights for this AIDS 2024 conference. You have shared a lot of valuable insights, and you have brought in a lot of clinical pearls as well. Sir, with your permission, there are a few questions in the chat box. Can I take them?
Yeah, please.
Yeah, so the first question is from Dr. Rakesh Bharti, who is saying that any chance of bictegravir plus 3TC combination in the future, or how do you see this combination?
Yeah, I mean, it should work, but we don't have this combination being bought by the originator company. They currently have only the FTC with the TAF. So I think I would not see much difference in terms of DTG 3TC performing similarly in that context. But unfortunately, I don't see this being available in future.
Okay, so I also request the attendees, doctor, to please put in their questions in the chat box. I'll take, sir, the second question. This is from Dr. Ravi Teja. He's asking, sir, why TAF FTC is not preferred for vaginal sex for PrEP?
Yeah, so the studies which have been done in cisgender women had demonstrated lower efficacy with the TAF FTC, and also it was true with TDF 3TC, but there it was believed that there was lower levels of adherence. there was a linear relationship with good adherence and efficacy of the PrEP. But there is a concern about the actual concentrations achieved in the vaginal tissues of TAF-FTC as compared to TDF based regimens, while TAF-FTC achieves excellent levels in the rectal tissue. There is some evidence to suggest that there is maybe some problems of tenofovir levels in the vaginal tissue, and that is being further studied. So we still don't have the answer for that. We don't have the evidence right now, and that is the reason why we suggest TDF or people suggest that TDF based is better than TAF for vaginal sex.
Okay, thank you, sir. So, sir, we have few doctors who are attending live from Tirupati. So again, I request them to post any questions or, yeah. So this another question is that now this is a practical question. So in an HIV, there is a HIV positive male who is virologically suppressed, and his spouse is there, and they are planning to have a child. So his question is, do we advise PrEP or is it not required?
Yeah, so this is the undetectable equals untransmittable concept in HIV. If an individual is on antiretroviral treatment and has been undetectable, sustained undetectable, then the risk of sexual transmission of HIV, regardless of what kind of sex they have, is zero. So in this context, I think as practitioners, we need to proactively tell our patients that U is equal to U. You don't need to really have to use a condom, whether for conception or otherwise also for prevention, because the risk of transmission is zero. But the most important aspect is, of course, this has to be in the context of good adherence to antiretroviral treatment and good monitoring of viral loads. Because both of these components are important to ensure that the individual is undetectable and is incapable of transmitting HIV to the sexual partner.
Okay. There are a few questions more. I'll just take them. There is one more question, sir. What is the preferred ART for serodiscordant couple?
Doesn't matter. Whichever is the ART, the goal is to achieve undetectable levels in the index partner. And once the partner is undetectable, whichever is the regimen, the risk of transmission is zero.
Okay. There are a few questions. So there is another question from Dr. Praveen that do you think, sir, we are moving from a 3-drug regime to a 2-drug regime, and maybe in the future 1-drug regime?
Well, one drug regimen is something which was already tried. DTG monotherapy studies have failed. The real issue is failing with resistance. If you start developing resistance, then in that context, your entire class may get really knocked off. So at this point of time, we have 2 drugs. Even for the injectables, we have cabotegravir and rilpivirine as 2 drug combinations. And the problem again with that was that when people failed the cabotegravir rilpivirine regimen, they actually failed with the integrase resistance. So that is something which is bad really, and that resistance which emerged with cabotegravir has cross resistance to DTG and bictegravir. So we have to be very careful when we talk about single drugs, etc. We don't have evidence for that. With 2 drugs, it looks like even with a partially active lamivudine, with some historical resistance or even active resistance, with by the ability of that to reduce viral fitness, maybe it may be useful. So a 2-drug regimen is going to be here for at least some time.
Okay, so just for the question, so 2-drug regimen will be used for those who are virologically suppressed or naive patient as well?
So you can use it in naive patient. The Gemini M2 trials for DTG 3TC have demonstrated its non-inferiority with a 3-drug TDF based regimen. Previously, there was an idea that we basically have to rule out high viral load, more than 500,000 copies, prior to initiating them on two drugs. But multiple subsequent studies have demonstrated that the baseline viral load may not be really necessary, because efficacy is decent in that context. Of course, we need to rule out active HBV infection. Somebody who's HBsAg positive can't be given a two-drug regimen, as well as somebody with active tuberculosis, because we don't really have data of doubling the dose of dolutegravir with a two-drug DTG-3TC, along with concomitant rifampicin. So except these few contraindications, there is no reason why we should not use DTG-3TC, a two-drug regimen, in the context of first line.
Right, sir. There are Dr. Sachin saying it is a very informative session. Dr. Rifa Khan says excellent summary, sir. So she had just posted one a comment that TAF has impact on lipid profile and it is likely to increase the risk of hypertension, maybe in the first 2 years of daily use. So your take on that, sir?
Well, this is something which is quite complicated areas. Things are not very clear. First of all, most of the data that is coming out is in the context of weight gain and its subsequent metabolic complications. So there are two issues here. One is whether TAF is weight neutral or by itself is causing weight gain, or whether TDF is weight suppressing, and the reason for that is not clear, and that weight suppressing effect, whether it translates into less metabolic complications. So somebody who switches from a TDF to a TAF has a higher weight gain. We really don't know what's happening in that context. But most people believe that TDF weight suppressing effect, when it is removed, you actually has a rebound of weight which happens in that context. Of course, with weight gain, there is significant metabolic consequences associated with it. And this includes right from increasing the waist circumference to visceral adipose tissue, to hyperlipidemia, to cardiovascular risk. So all of these things have to be closely monitored for. But at this point of time, choosing of regimens based on metabolic factors is not really very popular. But what we do in our clinical practice is somebody who has an EGFR above less than 90, we try to avoid TDF in that context, and above 90, we are okay with giving TAF.
Okay, thanks, sir. Sir, do you think, sir, this is a question again from Rifa Khan, do you think that PrEP needs to be individualized?
Yeah, of course, everything is individualized. So you basically need to assess high risk of individuals. How do you define high risk? So in that context, you have individuals who are consistently practicing high risk, have a history of STIs in the past. So that's a surrogate marker of high risk behavior. And the individual has to commit to full adherence to the PrEP regimen. And then we also have individuals who may have baseline comorbidities like say CKD, and in that context you may not be very comfortable using TDF based regimen as compared to say TAF. So all of these things have to be individualized, but most important thing is of course adherence. There are of course two different ways of giving oral PrEP. You may have a daily oral PrEP for individuals who consistently have high risk, who perceive themselves to be having consistently high risk behavior, or you may have what are called as event driven PrEP. So in event driven PrEP, you basically plan for having taking PrEP in what is called as a 2:1:1 regimen. So you take 2 pills of TDF based regimen 24 hours before the event, and then one on the day of the event and one after the day after. So this regimen is also, so again, these are all discussion and you can individualize it. But most important is after starting PrEP, we need to, particularly for daily PrEP, monitor these individuals for renal safety and for other STIs. Remember, because once we have PrEP, people may have risk disinhibition and they may get other STIs. We have to tell them that it doesn't protect against other STIs. So monitoring for those STIs, monitoring for safety, and of course monitoring for HIV as well.
All right, sir. This is a question from Dr. Prakash Bora. So he's asking, sir, lenacapavir is a therapeutic tool. He's asking, how will it be used?
So in therapeutic pool, there are various studies which have looked at using lenacapavir. Lenacapavir is available orally as well as subcutaneous. For the prevention, it is used subcutaneous every 6 months, or proposed to be used. But for treatment, it is used as an oral formulation. So it is used both in context of simplification of a regimen, as well as it is used for multi-drug resistant. So there was one study looking at, I think, lenacapavir with islatravir for multi-drug resistant individuals, and it showed good virologic suppression rates. At this point of time, for therapeutic, I think it is something which can be used for simplification as well as for MDR-HIV.
Okay. Thank you, sir. Dr. Milind Kulkarni has posted that is an excellent presentation. Amazing and new insights are added. And he's asking a question when we can have injectables in India. So basically, this all depends on the patent expiry and the application to DCGI and so on. Yeah. There is a question from Dr. Niranjan Rathod. What are the chances of developing lenacapavir resistance with twice yearly PrEP?
Unfortunately, we don't have data for that. One thing is breakthrough HIV infection happening in the context of this injectables. We have data for cabotegravir, which is approved every 2 months as an injectable for PrEP, where they demonstrated cabotegravir resistance emerging in the context of breakthrough infection. Now, most breakthrough infections are happening mostly because acute HIV infection has not been ruled out when the PrEP was started. So in these individuals, the HIV RNA was not done, the ELISAs were negative, they may have been in the window period, and then you initiate. So actually, then you are giving suboptimal ART to these individuals as a monotherapy, and there is rapid emergence of resistance. True breakthrough infection also happens with cabotegravir, and there have been resistance. There is a very interesting syndrome called Levi, which is seen with injectable cabotegravir-based PrEP, where what happens is if there is a breakthrough infection, because there are drug levels, because these are having long half-life in the body, that's why you can give it every 2 months. Because there are drug levels, the acute HIV infection is attenuated. The symptoms are attenuated, the viral loads are low, the antibodies do not come very early. So the diagnosis of HIV, breakthrough HIV infection also becomes difficult. So this is an emerging field. We need to keep an eye on this and how to really monitor these individuals.
Right, sir. So there is a question from Dr. Ravi that with lenacapavir, do we see an epidemic of other STIs coming or emerging?
Well, there is in terms of other STIs, I think we have some data from the developed world, particularly US, where they are seeing an increase in syphilis, which is happening as PrEP has been scaled up. Though PrEP scaling up, even in the developed world, even with the oral PrEP, has been not significant. For those people, as compared to those people who are eligible, hardly a few percentages are receiving PrEP. So in this context, I think, yes, STIs are something which needs to be monitored for. They can emerge with PrEP because of risk disinhibition. But most importantly, also now we have some data for doxycycline PEP to prevent the 3 common STIs like chlamydia, gonorrhea, and syphilis.
Right, sir. There is a question from Dr. Neha Garg. Just a question, sir. Do you see incidence of HIV in children nowadays?
I don't know. I have not seen for many years now a newly diagnosed kid with HIV.
Okay. So there is a question from her that any new formulations for children who are weighing less than 20 kgs?
Well, I don't manage these patients, but whatever kids we had previously, we used to refer them to the government program because we just don't have pediatric formulations in the private market.
Right. So there is a question again. So this is the question from Dr. Neha. There are further questions now coming in. So this is from Dr. Praveen, that if a patient is on a DTG TTC and the patient gets TB, should it be changed to TDF FTC or a double drug regimen?
Yeah, so there are 2 aspects to this. One is, of course, we don't have data for DTG-3TC with concomitant rifampicin and doubling the dose of dolutegravir. So obviously, at this point of time, we need to change them to a TDF based regimen. Now, whether we add an additional dose of DTG to that or not is something which also is in the context of virologic suppression, etc. Because there is a study which was called the Radiant TB study, which compared DTG doubling versus DTG OD, and really did not show any difference in virologic suppression rates. But as far as guidelines are concerned, if it's still possible, we should double the dose of DTG. If for some reason doubling of the dose is not possible, and if the patient is virologic suppression, developing TB, then you may be able to get away with a DTG-based non-doubling dose with TDF. Of course, you have to move away from DTG-3TC.
Right, sir. Thanks. Yeah, so there is again a question from Dr. Prakash Bora. So, which drug he is asking is responsible for weight gain and dyslipidemia? Is it DTG or is it TAF?
I told you this is an emerging field. This is very complex. And as already mentioned, whether TDF and efavirenz have weight suppressing effect. Whether TAF and integrase inhibitors are weight neutral or independently cause weight gain is still unresolved. And in that issue, particularly in naive patients, it's very difficult to tease this out because there is a return to health phenomena which happens. There is a catabolic state which is there with uncontrolled HIV, and you initiate somebody on ART, and regardless of ART, they gain weight in naive individuals. You can only study this in switch situations, and switch situations are very complex. People switch from all kinds of regimens. So in that context, I think it's not very clear. Many people believe that, and there's a beautiful editorial in the Clinical Infectious Disease teasing this out, believe that TAF and integrase inhibitors are weight neutral. And there are, of course, a few group of people who believe TAF and integrase inhibitors independently cause weight gain. So we don't know that answer yet. There have been, of course, some studies looking at reversing the weight gain. So if somebody is on, there is a characterized study, which was basically an extension of the advanced trial in Africa, where people were switched back from TAF, FTC, DTG, or TLE, and the TDF, lamivudine, dolutegravir. So these were the 3 arms, and people with the weight gain were switched back to TLD as the government program offered TLD. What they saw was a decline in weight when switching from TAF to TLD, and an increase in weight happening when switching from TLE to TLD. So here you can see you are going away from TAF and going to TDF. So whether removal of TAF causes weight loss or introduction of TDF causes weight suppression is not really clear. So we need to really wait for further data.
Right, sir. Right, sir. So there is a question from Neha Gupta. Should we continue TTC when the patient is virologically suppressed on darunavir 600 and DTG?
Well, darunavir with DTG in the D square EFT trial I showed you clearly showed suppression by itself. So there is no need for 3TC upfront in this context. If you are switching away from an NRTI-based regimen, and because it's 600 of darunavir, I assume that there is no PI resistance.
Okay. So the lot of doctors are asking their questions because all of them need your expert advice. So there is a question from Dr. Rupa Agarwal. Okay, so her question is, suppose a HIV positive patient in India comes to you because she has read about the twice yearly injection for HIV on the internet. Okay, so do you consider giving 6 months doxycycline to your patients in your clinical practice?
At this point of time, we are not really translating the doxy, PEP, or PrEP. PrEP is so very basic. Still, it's a pilot trial. So PrEP data needs to come. These are two observational studies. There is a phase 3 trial being recruiting now in the US looking for doxy PrEP. So, and this is predominantly in MSM population. So you should always have that idea in mind that most of these studies, except the Tokyo study, was in female sex workers, but that is again a retrospective observational study. So at this point of time, we don't have strong. Otherwise, it happens similarly for what happened with HIV PrEP, where cisgender women showed lower rates of efficacy, and this was tied up with adherence, but we don't really have strong information of why women had lower rates. So in this context, doxycycline PrEP or PEP is something which we still do not practice. But doxy PEP is already being recommended for very high risk individuals in the developed world. Particularly, the CDC has guidelines on this, and they have certain criteria for defining what is high risk. And that includes MSM population with history of STIs in the previous 6 months, etc., etc. So in that context, you can perhaps consider, but at this point of time, particularly with the impact of AMR, emergence of resistance with widespread use of antibiotics, which we are trying to curtail overall in our population, this is not a good idea.
Okay, sir. Thanks, sir. Dr. Praveen Kulkarni has complimented you for your excellent presentation. And sir, in this Munich conference, there was one paper as you presented. If there are any sleep disturbances with dolutegravir, there is a study where you can shift to bictegravir. So your advice on this?
Yeah, so I showed you that data. I
Yeah.
showed you that, of course, this is a very small number of 12 and 6 patients, where they showed improvement in patient-reported outcomes by questionnaires, as well as changes in functional MRI. So you may try this out, but most of the times what happens is patients on a DTG having insomnia, the first thing we do is try to put them onto a morning dose rather than a night dose. So that basically corrects most insomnia for patients. And if now, of course, this is new for me also, so we can see how it works in practice.
Right, sir. Right, sir. Sir, just one question that what do you feel are the differences between dolutegravir and bictegravir in your practice?
I think the issue here is, of course, staph FTC. Bictegravir has staph component. You can't have TDF in that. So in that context, you can't use it with rifampicin right now. And so you have predominantly TDF that has to be used with rifampicin. In terms of differences between these two, there is not much difference in terms of efficacy, in terms of safety, and umpteen number of trials and umpteen number of scale-up studies also. But because there were very beautiful studies, I didn't cover it, of high numbers of scale-up results from Africa, which was presented at the meeting, which demonstrated excellent safety and efficacy with TLD. So it is something which perhaps depends how much individual factors as far as patient is concerned. makes a difference, I'm not really sure, because except for rifampicin, I think they are head to head in terms of efficacy and safety.
Right, sir. And in terms of the renal profile?
Yeah, so TDF is something, as I told you, in our practice, if somebody has an EGFR less than 90, we would prefer them to give a TAF-based regimen because of progression to CKD, which is defined as an EGFR less than 60. In above EGFR of 90, you can either choose a TAF or a TDF-based regimen. Doesn't really matter. In terms of bone toxicity, we have to remember that people always believe that TDF is associated with bone toxicity, but the best results for the incidence of bone toxicity comes from the START study. In the START study, there was an initial grade. When you start ART, irrespective of whether it is TDF or any other ART, there is a slight decline in BMD which happens after starting ART. This decline is a little more in the TDF-based regimen, but it plateaus after 1 to 2 years. So whatever BMD decline happens in the initial 1 to 2 years, and after that it doesn't really matter. So people have this concept that long-term TDF causes cumulatively more bone toxicity, but that's not really true.
Right, sir. Right, sir. So, sir, we'll take one last question now. This from Dr. Neha Gupta. So, what is the dose of doxycycline in PEP? Single day 200 milligram, or it has to be continued for a few days?
This study continued it for 6 months.
Okay. Yeah, I think thanks, sir, for your valuable advice and giving your valuable suggestions for all the queries which have been asked by the doctors. And I wish to thank you, sir, for your excellent deliberation and also your expert advice to the doctors. A few doctors were live from Tirupati, and I thank you for your excellent presentation, sir. Thank you, sir. Thank you.
Thank you.
Thank you, Doctor.
Yeah, so I request Mr. Balaji, sir, so to give a vote of thanks for this webinar.
So it was very interesting to listen to Dr. Sanjay for having brought to us the highlights of the 5 days conference in a 1 hour session with so much of information at our fingertips. So we are indebted to him for repeatedly accepting our invitation to host this event, and there is a lot of it shows his lot of dedication and his interest in this particular field. So thank you, Dr. Sanjay, once again, and it has been a pleasure to be associated with you, and I'm sure Dr. Fraternity and others who are in this field are enlightened with this presentation. So wishing everybody a happy weekend, and thank you, Dr. Sanjay, once again. Good evening.
Good evening. Thank you. Thank you, sir. Yeah, Vivek, can we close?
Yes.
Thank you.
Thank you. Thank you, sir.
Thank you.
Thanks, Nandakishore. You can close this event.